So post-AVH cholestasis, actually I have detected the hepatitis A is the most common viral hepatitis we know. So in viral hepatitis A, we see that more than 90% spontaneously resolve. And if we see the prevalence of cholestasis is around 10 to 20% with the incidence less than 10%. This is the overall prevalence. Mean incidence is around 5 to 10% only. The relapsing hepatitis is around 5 to 10% also. This is the prevalence overall, and the permanent hepatitis less than 1%. So these are not very frequent, but we usually see these patients in our OPD and ICU. Those patients, this has been a definition used for the post-AVH cholestasis. This is a very well definition. This is not actually a strict criteria, but usually we use these definitions like peak bilirubin of more than 10 mg per deciliter with the direct bilirubin fraction of at least more than 50% and jaundice duration of more than 12 weeks, along with the absence of hemolysis and renal failure. And ALT levels should be below 500 to diagnose the post-AVH cholestasis. So coming to the natural history of AVH, we see that it starts with the prodrome and there is a ecteric phase, and this subsides in around 6 to 8 weeks, and it becomes to the normal baseline in around 2 to 3 months. So the enzyme levels also come down along with the bilirubin levels in the normal course of the viral hepatitis. But when we see the AVH with cholestasis, there is a plateau phase of the jaundice, and there is a prolonged cholestasis phase, pruritus associated with the jaundice, and it prolongs for more than 3 months, around 12 to 16 weeks, and it is a self-limiting course, but the significant pruritus can be troublesome for the patient. So it is so troublesome that even patients, there are case reports of patients having suicide during the episode of pruritus for the AVH cholestasis. So it is a very troublesome and very significant clinical complication of the AVH. Differential diagnosis to be considered in this phase is most important is drug-induced liver injury, because it is very common to have patients have the herbs for the persistent jaundice, and second is the biliary obstruction. So how we can differentiate between drug-induced liver injury versus post-AVH cholestasis? So drug-induced liver injury will have temporal relationship with the herbal products or any other drugs which has been abused, and also the level of jaundice will correlate with the enzymatic activity. In post-AVH cholestasis, the enzyme levels will come down, but the jaundice persists along with the pruritus. But in drug-induced liver injury, there will be high enzymatic activity along with the jaundice. Second is the biliary obstruction. We need to rule out by the imaging and ultrasonographically. We can rule out the biliary obstruction by the dilatation of the bile ducts. So, which patients will be developing this complication of the viral hepatitis, and what is the possible mechanism? The mechanism is mostly humoral and the precholestatic polymorphism of the hepatocanalicular bile salt transporter. And those patients who have co-infection with viral hepatitis B, along with the older age and high bilirubin levels, and those who have high PT-INR are more susceptible for this post-AVH cholestasis. So coming to a case to make you understand better, the case of 27-year-old male who presented with the jaundice of around 1.5 months along with the itching for 1 month, with no history of biliary colic to rule out the extrahepatic obstruction, along with there is no history of fever with chills or any surgery to rule out the extrahepatic obstruction, no history of prior jaundice to rule out the autoimmune hepatitis and other recurrent jaundice, no history of the ascites, encephalopathy or GI bleed to rule out the chronic liver disease, no history of hepatotoxic medications we have to take before diagnosing cholestasis of post-AVH, because to rule out the drug-induced liver injury. And also other autoimmune features needs to be ruled out before diagnosing the post-AVH cholestasis. On examination, patient was deeply ecteric. There were scratch marks. So this scratch mark suggests that patient is having severe cholestasis, and he must require some interventions for this cholestasis. So patients having a scratch mark or having disturbed sleep due to pruritus is a sign of severe pruritus. So there was no cutaneous bleeds, soft palpable liver to rule out the chronic liver disease. Generally, the patients with the viral hepatitis have soft palpable liver, so it confirms our diagnosis. No splenomegaly or ascites, and other systems are normal. On laboratory investigations, bilirubin, which was initially 30, came down to 22. SGOT, PT were also coming down. More than 16 times upper limit normal initially, came down to 4 times. And the ALP levels are persistently elevated. Hepatomegaly along with the no ISBRD, and IgM anti-HEV was positive, so it was post-AVH cholestasis with HEV positivity. So this was acute hepatitis C, prolonged duration along with cholestasis. So how will we manage? So generally these patients do not require aggressive interventions. We need to monitor the patients and give nutritional therapy along with the supplementation, and the only treatment required is for the pruritus. The pruritus is significant, patient is having intractable pruritus or grade 3 pruritus, we need to intervene. So the first line therapy for pruritus in such patients is ursodeoxycholic acid and cholestyramine. Second line being rifampicin and antihistaminic. Third line being opioid antagonist and ondansetron or sertraline. So drug in the cholestasis are primarily, we do not have data on the post-AVH cholestasis, but the data is primarily based on the other cholestatic disorders. Very little data in AVH-associated pruritus. So cholestyramine, which is a anion-binding resin, which helps in excreting bile acids through the intestine. So we have data on the other diseases, but no data on the post-AVH cholestasis currently. Rifampicin can be safely used in such patients post-AVH cholestasis, and it has been found to be useful in the PBC patients also. So we have experience of using rifampicin in post-AVH cholestasis. It converts bile acids into those metabolites which do not cause pruritus. So non-pruritic metabolites have been metabolites to non-pruritic metabolites of bile acids. Anti-opioids, we can use naloxone, naltrexone, or nalmefene. There is reduction in the pruritus score. This data is also again in the PBC patients. Also, we also have post-AVH patient experience of post-AVH cholestasis in around 15 patients. There was median reduction of pruritus. IV naltrexone has been used, and there is 80% improvement in the cholestasis in patients with the AVH. Ondansetron, although is used in post-AVH cholestasis patients in which there is pruritus associated with the nausea and vomiting, because in cholestasis the chances of improvements are less. So there is a doubtful benefit of adding ondansetron. So in those patients who have nausea and vomiting associated with the cholestasis, we can use this drug. Sertraline also has been shown to have some improvement, around 33% of the improvement in pruritus score with the drug. So ursodeoxycholic acid we are usually use in routine because it solubilizes the bile, and it also helps in excretion of the bile, and also it reduces the toxicity of bile acid. So it is very useful for this management of cholestasis. Coming to the non-pharmacological measures, general measures like avoiding the hot weather, frequent cold water bath, avoiding the rough cloth, and avoiding the tight clothing along with the use of emollients can also be useful. Take home message will be very little quality good data for the any drug on acute viral hepatitis associated cholestasis, and most patients resolve with the time, but non-pharmacological therapy may be useful. Rifampicin is the best based on the data from the other liver diseases, but it is risky currently. So other drugs may be tried, but under the careful observation. Thank you.